We also are looking at both we presented at the abstract, in the oral abstract, but also as a poster. The investigators on the study identified patients who had received the TIM-3 inhibitor sabatolimab in the context of the trial, and at any point later on went on to transplant. And this is an area of interest. We worry about giving a checkpoint inhibitor, especially an antibody that can linger in the body, and then resulting in kind of more concerning graft versus host or immune-related toxicities post-transplant. Fortunately, we did not really see a marked signal. Now, this is a small group. The number we're presenting at the poster session is about 29 patients, 19 of whom had MDS. So it's a relatively small look at who could go to transplant. That said, the number of patients who experienced severe GvHD was relatively low, and I think early signals of overall and progression-free survival after transplant are encouraging. So, at the least, I think we don't see a signal that would preclude a patient who received sabatolimab from going to transplant. And if anything, there's some potentially encouraging signals that maybe we're getting good post-transplant outcomes. I think the excitement here in this field, as in most of MDS, is that this is moving into phase 2 and phase 3 randomized studies. Hopefully we'll have a wealth of data from these randomized trials in the future to both look at how response rates differ compared to azacitidine alone, look at how durations of response may differ between these agents. If you think you've got immunologic control of your disease, do we see that translate into a longer response? And similarly, I think the post-transplant outcomes in those studies will be really interesting. Can we optimize disease better pre-transplant so that we are curing more patients post-transplant? And so all of that, this is some preliminary data, but hopefully we get to see some real results come through.